Good morning, good afternoon. My name is Akudo Ikpeazu, and I lead the HIV, tuberculosis, hepatitis, and STI program in WHO in the African region. My presentation will aim to update us on where we are 1 year after the release of the updated guidelines on hepatitis B. My presentation will focus on three key areas. First, a brief introduction of the context, where we are 1 year after the launch of the new hepatitis B guidelines, and strategic priorities for going forward. The Global Health Sector Strategy 2022 to 2030 provides the strategic direction with a vision to end AIDS and epidemics of viral hepatitis and STIs by 2030. It also puts forward an integrated approach across disease areas and within broader health systems to achieve universal health coverage. Key targets for viral hepatitis elimination are very clearly defined. The 2024 WHO guidelines, what changed? Major updates in the 2024 guidelines include, first, the simplified treatment criteria with reduced complexity to overcome access barriers, enhanced prevention focus, including strengthened mother-to-child transmission prevention protocols, diagnostic improvements, hepatitis delta integration, service delivery optimization, including decentralization and guidance on integration into other health services. So 1 year after, where are we? The Global Hepatitis Report for 2024 showed that the region accounts for 63% of all new hepatitis B infections globally. 65 million people were living with hepatitis B. 33.6 million children under 5 years accounted for 64% of all children living with chronic hepatitis B globally. Critical gaps in hepatitis B birth dose vaccination exist, with only 17 countries providing it as part of routine immunization. In terms of the picture for the 10 highest burden countries, which contribute up to 80% of the burden for the region, there is indeed a diagnosis and treatment crisis. So where are we? Looking beyond the data from the 2024 global report, we conducted a rapid qualitative analysis of 30 countries. The purpose was to rapidly assess the program capacity and progress across countries in the region to identify strengths, gaps, and opportunities for improvement. The survey tool addressed 8 thematic domains: quality and standards, program management, prevention and treatment, the cascade of care, data systems and governance, hepatitis B prevalence, and EMTCT, as well as financing. Overall, the responses to the 47 questions revealed a mixed landscape of progress and challenges. The areas of interest in more detailed included availability of surveillance systems, testing and treatment of eligible people, universal birth dose coverage implementation, screening and treatment of pregnant women where indicated, national strategic plans and subnational planning and programs, funding for hepatitis B services, including co-pays and health insurance, national governance structures, community engagement, and uptake of WHO guidelines. Performance, as we saw, varies significantly across thematic categories, revealing areas of strength and critical gaps in hepatitis B capacity. The strongest category was in quality and standards, where strong adherence to WHO standards was noted. We would note here that the guidelines, the view on the guidelines was not only about what has been updated for 2024, but more generally about the guidelines which were already adopted by countries. Now, in terms of the weakest category, we saw that was in financing, as well as EMTCT and estimation of related indicators. There was a universal acknowledgement of insufficient funding. In terms of the strengths and the gaps, we note that while countries excel in WHO protocol adherence and testing infrastructure, as shown by the green bars, critical gaps exist in funding, prevention programs, and local implementation, as shown in the red bars. This next slide provides further details on prevention programs and shows that the critical gaps exist in prevention programming, particularly for prevention of mother-to-child transmission, which could perpetuate hepatitis B transmission cycles despite treatment advances. Despite the overall picture, the success of Namibia shows that progress in the region is indeed possible, even in very high burden settings. Namibia became the first high burden country to be certified on the path to elimination of mother-to-child transmission of hepatitis B. Of particular note was the coverage of up to 92% on first dose coverage and 94% on the third dose coverage. With regards to the funding crisis, there is indeed a funding crisis for hepatitis, and this is a little bit bigger than the ongoing challenges that we see within the funding landscape. Financing was the weakest link and remains the weakest link in the response across countries in the region. There was universal acknowledgement of insufficient funding, which threatens the sustainability of elimination efforts. However, we see that some countries have made progress as a result of government investment. And Rwanda, as well as Uganda, provide two excellent examples from which other countries can draw inspiration. So what were the key learnings and insights from what has happened over the past 1 year, as well as this rapid analysis we've conducted? We see that the simplified guidelines were conceptually very well received across all countries. We, however, note that there is a huge implementation gap and the speed is too slow for the 2030 targets. Although there's a growing focus on prevention and point of care testing, which is showing increasing promise, more needs to be done in improving access to treatment, but even more for preventing new infections. There is universal acknowledgement of insufficient funding and poor sustainability arrangements, as well as a deficit of data, especially for informing subnational evidence-based decision-making. Learning from all of this, some key priorities for going forward. We would like to see that we can all work together to take forward some of these priorities. We see that the window for achieving the 2030 targets is rapidly closing and there's an urgency to accelerate implementation. Political commitment and leadership at country level will be key for mobilizing sustainable financing and integrating hepatitis B services into broader health financing schemes. Prioritizing prevention of mother-to-child transmission, especially in the context of triple elimination, will also be key. Bridging implementation gaps, including investing in health workforce capacity building to support decentralization, as well as strengthening data systems to improve decision-making and monitor progress. These top priorities have informed the new WHO Afro-Hepatitis Community of Practice, which will be rolled out in the coming weeks to actively support countries, especially the 12 highest burden, in their journey towards elimination. As I end, 1 year after the release of the 2024 guidelines, we see a complex landscape of strong technical foundations, but critical gaps in funding, prevention, and local implementation that threaten hepatitis B elimination goals. Urgency is therefore needed, but also commitment to partnering in a way that helps us boost efficiency in response to the global health financing challenges will really be critical. Thank you.